Today I'm going to talk to you about uterine myomas and see what are the new options. And I'm very conscious there are mixed audience in this hall. So what I'm going to do, I'm going to introduce the subjects, and maybe it's a bit mundane and simple, but for the benefit of the nurses or allied health in the audience, then we'll cover a little bit on the pathophysiology, the symptoms, signs and symptoms of presentation, and just remind you a little bit about fecal classification, the options of management, and later on think and zoom in what's new in the management of uterine fibroids, and conclude from there. All of you know that uterine myomas or fibroid are very common among women, and that's one of the commonest benign tumors, and these tumors arise from the smooth muscles, and myomas actually arise from one single smooth muscle. It can be single, but a lot of times when women present with signs and symptoms of myoma or fibroids, they're usually multiple. I said just now it's made of smooth muscles, and it's only comprised of one. It comes from one single smooth muscles. And usually it has a pseudo capsule, and all the OBGYN are quite aware about that. And when we see in ultrasound, well circumscribed and a tumor. And this capsule, in this pseudo capsule, there are bridges of the collagen and blood vessels that comes from the periphery. So meaning to say, as the fibroid gets larger, the blood supplies that feeds the myoma actually come from the periphery, and the center of the myoma dies off. And this is how it can have complications like rate degeneration or cystic degeneration as the fibroid gets bigger and bigger. And when that happens, the woman can present with pain. And usually, of course, when it comes to pain, so then it can be a problem to a woman. Let us just zoom a little bit on the classification. I'm sure you're all aware about the classifications of uterine fibroids, and they're classified according to where they are anatomically on the uterus. So it can be submucosal, where most of it will be into the endometrial cavity, and this tends to present with uterine bleeding or abnormal bleeding or heavy menses. They can be intramural, which sits within the wall, and this is one of the commonest classification of uterine fibroids, or it can be subserosal, and it can also be pedunculated. But there are other presentations where it can be interligamentary or in the cervical area. So however, the presentation may be a bit different, and sometimes this patient doesn't present with abnormal menses because it doesn't understand the endometrial lining, but they can present with pain, and especially if they have pedunculated myoma, they can present also with torsion. I said just now in the introduction, it's very common. 4 out of 10, or sometimes up to 50 to 60% of women may present with myoma, and they can be asymptomatic. And usually they present at childbearing age, and the cause of the myoma, why it happens in some women is not understood, not well understood, but we also know that uterine myomas respond to the changes of progesterone in your body. So that's why in the olden days, traditionally before, we used to treat myoma with progestogen, with oral contraceptive pills, and most of the time it doesn't work, and sometimes the myoma gets bigger. Why is it? Because the myoma has progesterone receptors much more than the endometrium itself. So these are the risk factors of myoma. You're well aware about the risk factors. Increased risk factors can be with certain age group, like the African Caribbean, or in women who are obese, or you have the family history of myoma, because there's some genetic component about the myoma. Increased parity and increased age also is a risk factor. Now, research has clearly demonstrate that now the uterine fibroids responds to the natural estrogen and progesterone, and that's the reason why the treatment, the old traditional treatment, may not work in the uterine myomas in terms of bringing down the size, but it may work in terms of causing the bleeding to be lighter or the patient to be less pain, but it doesn't sort of have any effects on the myoma. We said just now the etiology is unknown, and we said just now it depends on the progesterone receptors, because we know that in the myoma there's a lot of progesterone receptors. So if that's the case, then anti-progestogen agent can be a treatment and can be useful. What are the other anti-progestogenal agent or progesterone receptor modulators? One example is RE486 which is not available in our country. And you can have selective progesterone receptors, which we'll zoom in a little while. What does the myoma cause to the patient? Because of the symptoms, it can give rise to pain, it can give rise to abnormal menses, they can have anemia, and also it will affect their quality of life. And a lot of women suffer in silence, and they may not come to see us until they have a lot of problems. So basically, the signs and symptoms of myoma can be divided into bleeding complaints because of the mass effect complaints, especially if the mass are bigger, and if it sits near the bladder, it can give compression pain. And because the myoma occurs majority in the reproductive age group, and it can give complications during pregnancy. Let's look at this. So the commonest symptoms of myoma is heavy menstrual bleeding, or they can present with irregular menses. But when they have excessive menstrual bleeding, then of course they can present with anemia, which can be a problem. If you look at this particular study in our setup, we will see that majority of myoma and most of the studies are done in the West. But let's look at some of our studies. You look at our studies here, when we look at myomas which are confirmed undergoing UAEs many years ago, when we offer uterine artery embolization as one of the medical options in terms of myoma, and we see the presenting symptoms here, majority, more than 60% of them present with heavy menses, which is what the commonest symptoms are. And the rest present with pain, and they can present with mass effect, dysmenorrhea, and irregular menses. And if you look at the location where the myoma is, majority of the myoma are intramural compared to the rest. So that's the commonest site of the myoma. They can also present with reproductive symptoms or pregnancy complication. In reproductive dysfunction, if the myoma sits near the isthmus or near the conva, they can have a reduced subfertility, or they can have increased complications in pregnancy if this is elsewhere. And of course, there's an increased risk of miscarriage. We look at a small study looking at the presence of myoma in terms of pregnancy complications, and when we saw a patient from 2006 to 2007 confirm myoma on ultrasound, we saw more than 100 patients with in pregnancy with confirmed myoma. We find that they have 2 times increased complications in pregnancy, namely they can have prolonged labor, they can have postpartum hemorrhage, and of course cesarean section is slightly increased because of labor dysfunction, and also because of that it can also lead to lower outcome. So if the fibroid is more than 5 centimeters, then there's an increased chance of having complications in labor. They can also have symptoms of mass effect, depressive symptoms, or if the myoma is in the pelvis or in the lower abdomen, they can present with pain, or they can present as pain in the lower back, as backache. And sometimes they also can present urinary symptoms if the myoma sits near the bladder, behind the bladder, and this can cause frequent urination, or at times, sometimes complication, constipation, or painful sexual intercourse. So all in all, the presentation of the symptoms of myoma can also reduce their quality of life among women. How do we diagnose? Of course, examination, physical examination can diagnose myoma, but one of the recommended way of diagnosing myoma is by ultrasound. I put here MRI here, just because I wanted to zoom in into the medical options of myoma. In the study, where Pearl 1 to Pearl 4 study was conducted, when they were studying on the ulipristal acetate, all the patients had diagnosis by ultrasound and MRI. So we do not advocate diagnosis by MRI simply because it's expensive, it's not available. But if you do MRI, you can easily characterize the myoma in terms of where is it situated, and you can even count how many of them. But if you do an ultrasound, sometimes it's very difficult to characterize all the individual myomas. But ultrasound is enough as one of the mode of diagnosis. Now, for those of you in OBGYN, so you're quite familiar in the new classification of abnormal uterine bleeding into the FIGO new classification, where there are structural abnormality or without structural abnormality. And if you look at myoma, they're sub-classified into different categories, and this is useful in trying to identify which myoma you can do, for example, like hysteroscopic resection, or which you cannot do hysteroscopic resection. Let's look at the treatment options. Previously, the treatment options, we can have medical treatments, or we have minimally invasive procedures, or invasive surgical procedures. So in the invasive surgical procedures, you can do so many things. You either can do a laparoscopy, or you can do a hysteroscopy, or you can do a myomectomy, either open or closed. But these are invasive procedures. So in young women who wanted to have not completed their family, then of course myomectomy is an option. But the thing is with myomectomy is if you have so many myomata, so when you remove all the myomas, then they can increase the risk of bleeding. And this can translate, the bleeding is a lot, it can be translated into inadvertent doing hysterectomy to address the bleeding. Of course, this becomes undesirable. You can do myomectomy either open or laparoscopy. Nowadays it's more fashionable to do laparoscopic myomectomy because the hospital stay is much less. Of course, you need more skills of training because you can have complications during laparoscopic myomectomy. And sometimes you need more sedation, especially if the myoma is big. And the risk of sarcomatous changes in myoma is extremely small, and that's 0.1%. But if the myoma is bigger, and if you use more sedation, then you may miss the sarcomatous changes. Inadvertently, quite a lot of patients with myomatas are offered hysterectomy, but hysterectomy should be the last option because there's a lot of women sometimes doesn't want hysterectomy despite having abnormal menses, and this can be a problem because the symptoms will be carried on and they will end up having anemia and subsequently needing blood transfusion. We talked just now a little bit about hysteroscopic ablation, especially if the FIGO classification of 0 and 1, where the myomas or the submucous myoma is easily accessible by hysteroscope. And of course, again, hysteroscope is a non-invasive, it's a daycare procedure, and it's non-invasive, and it's still competency is needed, and still training is needed because the complications can include uterine perforation, fluid overload, and also it can cause uterine adhesions. The other options of non-invasive, previously we used to offer uterine artery embolization. In uterine artery embolization is usually performed by the radiologist, where they embolize the branches of the uterine artery that feeds the myoma with microspheres. And why they do this? Because they wanted to induce necrosis in the myoma. But by inducing necrosis, it can also result to complications in terms of causing inflammatory changes, causing fever, endometritis, and pain, and can also cause groin hematoma and endometritis. But the thing is, when you offer uterine artery embolization, if the myoma is big, and if it's a lot of myoma, it usually does not work that well, and there are more complications in terms of offering this for people who have more than one myoma, or if it is very big. And usually shrinkage is up to 50%, but they tend to recur because you will not be able to address all the myomas. Previously, the MRI focused ultrasound or HIFU without MRI is fashionable in terms of one of the options of myomas. The thing is, how does this develop? Earlier on, many years ago, when people has a liver cancer with metastasis, metastasis to the liver, and they have small liver metastasis, they use the ultrasound to sort of burn the small metastasis. And that's how people get the idea that maybe we can also do that to the myomas. So what does this focused ultrasound beam, and usually it's at 65 to 85 degrees centigrade, what it does is it causes necrosis. So when it causes necrosis, it also causes pain and inflammation. But if the myoma is big, this will not work and it will fail. And if there's a lot of myomas, and it also will fail. So the symptom relief is very small and the recurrence is high. So now it's not one of this HIFU, MRI guided ultrasound, and UAE in the West is not one of their recommended options currently. So let's zoom into medical therapy. Some of our women doesn't like invasive surgical or non-invasive procedures, and they rather start with something simple, orally medical treatment. Previously, we used oral contraceptive pills to treat myomas, but this only sort of lighten the bleeding and cause less pain. But it doesn't do anything to the myomas. If you put progesterone or you give anything that has progestogen as a therapy, now we know that actually the myomas has a lot of progesterone receptors. So what it does is it makes the myoma grows bigger. So before we use it, because we didn't know, but when you use this kind of medication, it does cause the myoma in terms it presents with bleeding to cause the bleeding much less, but it does not do anything else to the myoma. We also use NSAID before, and this is a painkiller to relieve pain, and also GnRH agonists. Now previously, rather than using oral contraceptive pills, we tend to use more GnRH agonists because it does reduce the myoma size quite efficiently. After you use GnRH, they are injectables once a month. After the second month, the myoma reduction in size can be more than 40%, up to 50%. They're quite effective in reducing myoma size and also reducing bleeding. But the problem is, you can't give GnRH longer than 6 months because you will create complications or postmenopausal complications like with GnRH usage. But the other thing is, once you stop the GnRH, because it's only shrink the myoma, then the myoma will regrow. And it will regrow to the normal size prior to using the GnRH. But it's also fashionable, but there are still some indications if people use GnRH prior to surgical procedures in terms of to reduce the myoma size and also to reduce bleeding during surgery. So what's new in medical option? Are there any new things that we know? We know that myomas has a lot of progesterone receptors. Therefore, if we have a drug that's anti-progesterone receptor, then it should work. Then it should cause the myoma to be less in size. So this is what ulipristal acetate is. UPA, or what is marketed as Esmya, is called a selective progesterone receptor modulator. Why is it selective? Meaning progesterone receptors are in many structures, in the uterus, in the bone, in the breast, and so on. So it depends on where they are. This ulipristal acetate will have different kind of agonist and antagonist action. Now, because that it blocks the progesterone receptors, and because the myomas or the fibroid has progesterone receptors, once it blocks it, so what it does is it causes it to shrink. But the other important effect to it, because it also reduces pain. I'll show you in a while how does it do this. Let me just introduce what is ulipristal acetate. Now, ulipristal acetate is SPRM. It is the recommended doses now is 5 milligram daily. It's used over 3 monthly cycles, 2 months off, and another 3 months. And 3 months is called one cycle, and 2 months no medication. And you start again after the second period to another 3 months. You completed 2 cycles. And depending on how big your myomas are or how many they are, you can either go to a 2 cycle or intermittent cycle of 4. Currently in Malaysia, initially it was approved for 2 cycles, but as of last year, now we have approval for 4 cycles. So the treatment-free, the 2 months treatment-free, what does it do? It allows the endometrium to normalize. I'll show you in a while what I mean. So when you look at this, so what is SPRM? So because it has agonist or antagonist action, depending on what tissue it is, and depending on how it is. So if there's transcription activation, then it becomes an agonist. If no transcription activation, then it becomes an antagonist. So in the myomas, it becomes an antagonist. So how does it work? Let's look at it. So the UPA in the endometrium, it has a direct action. What does it do? It downregulates the expression of the androgenic growth factors, and these will cause reduction in bleeding. And the other direct action on the uterine myoma is because it inhibits the proliferation of the uterine myomas because it has progesterone receptors, and it is an anti-progesterone receptor. So it inhibits proliferation, causing reduction in size, but it also reduces in size by causing cell death, which is apoptosis. And this we can see on ultrasound. And we see if you put patient on Esmya, we follow up the patient, you will see apoptosis on ultrasound. Now this is the difference with GnRH. In GnRH, it does not cause cell death. It does not cause apoptosis, but the UPA, which is in SPRM, cause apoptosis, causing cell death. And this is very important mechanism in reduction of uterine myoma. And this is because the progesterone expression in myomas is higher than the myometrium. Centrally, what does it do? It also affects the HPA axis, the hypothalamic pituitary ovarian axis, and it inhibits ovulation by inducing amenorrhea, and because and this will cause absence of menstruation in quite a number of patients. But when it does this, it has a central effect. Does it cause reduction in estradiol? Does it bring estradiol to the postmenopausal range? I'll show you in a while whether it does not. It does, but it does not bring the estradiol to the postmenopausal range. So meaning to say, the woman will still have normal estradiol level, therefore you do not need to have an ABAC therapy, even though you use the UPA for a long time. So how do we use UPA or Esmya? So as of September 2018, we have the approval of the indication of a 4 cycle. So usually you start in the first 3 months of continuous daily 5 milligram ulipristal acetate. Then you stop for 2 months, you had the first bleeding, and you had the second bleeding, then you start again the next 3 months. During this treatment-free period, the endometrium will normalize. Why is it important for the endometrium to normalize? Because during this period, there will be endometrium proliferation. Will that be a concern about the endometrial hyperplasia causing endometrial cancer? In the thousands of cycles which they were studying the Esmya early on in the phase 1 to phase 3 trial, and in the PEL 1 to PEL 4, what they did was the investigator did every single patient had endometrial biopsy. Every single patient at every cycle, and they find that the endometrium has there is proliferation, but none of the patients had endometrial cancer. Therefore, the recommendation at the moment is not to do endometrial biopsy, even though you find that there's endometrium thickening. So the question, I've answered some of the question in the earlier presentation. Let's look, is it effective? Does it cause hyperplasia malignancy? And is it safe? Do you need ABAC therapy? And how long can you use it? And I've said just now, but I will address some new concern in terms of safety. So this is the original trial. So they were looking about the dose regimen and how to give it. Initially, they compared it between 5 milligram UPA to 10 milligram UPA and leuprolide acetate. And you know that leuprolide acetate is very effective in reducing the size of uterine myomas, and is also effective in causing reduction in blood loss. So what did they find? Later on, and you find that, I'll show you in a minute later on, and in this particular study, they also find that the estradiol levels in all of the patients were not in the postmenopausal range compared to the leuprolide acetate. So we don't have to worry about the ABAC therapy. So when you look about the safety, and they've looked at the safety, the initial study, and currently more than 750,000 doses of UPA has been given worldwide. So it is safe, it's said to be safe and efficacious. And here it says that there is the increased risk of hyperplasia, but in none of the patients there was any evidence of endometrial cancer. So if you look at this, the comparison between the UPA and uproletic acetate in terms of amenorrhea time to reduction of bleeding is almost similar. So it is effectively reducing blood loss compared to GnRH, and this is reducing bleeding. So the time frame is the same. In terms of reduction in the fibroid volume, even after the first course, the more than 30% of reduction in the myoma volume, and after second course and third course, the reduction is maintained. And this one, even after the fourth course, and still maintained at 6 months follow-up. Of course, there's some regeneration in myomas in some patients, and there are some patients who will not respond to myomas. So about 20% of patients will still be a non-responders, and this patient, then surgical option would be the next step. If you look at the hot flushes in terms of the UPA, and if you look at the uproletic acetate, the GnRH, quite a number of patients will present with hot flushes because, and this is quite suppression of estradiol, so up to 40%. If you look at UPA, it's only about 11% of patients presenting with hot flushes. We saw just now the mechanism of action, and we say that it can induce endometrial hyperplasia, and this is what we call the progesterone receptor modulator associated endometrial changes. What's the difference in terms of the true endometrial hyperplasia? The difference, the key features in the PAEC is the glands are dilated, but they do not have a nuclear pseudostratification. And the number two difference is they have a low mitotic activity. So if you do a hysterectomy and the patient has been on UPA before, you have to tell your pathologist that the patient had been on UPA before, because they may see the PAEC changes in the patients who are put on UPA. Now, there are some concerns on liver. So let me just stop for a while, a few minutes to talk about it. Initially, when we started Esmya in the 2016, the initial recommendation in Malaysia was 2 cycles, but in the West, they already had a recommendation of 4 cycles. Somewhere in 2017, in February of 2017, we were asked to temporarily restrict the usage of Esmya because there were 5 patients in the US who had liver failure. And liver failure due to drug-induced liver injury, and 4 of them and some of them end up in liver transplant. And 4 of the patients were on Esmya at that point. So they temporarily stopped it. So let's look at the 4 patients. Now, this is the 4 patients that were had liver injury in last year in 2017. So what happened during the temporary halt, the EMA, what the EMA did was they asked the researcher to look at all the data in the phase 1 to phase 3 trial. So they look at all the data in phase 1 to phase 3 trial. Every single one of the patients in the initial trial had liver function tests. And all the patients, that there are more than a few thousand patients in that phase 1 to phase 3 trial, all of them had normal liver function tests except 4 patients in phase 3 trial. But the 4 patients in phase 3 trial, the 3 patients had more than 3 times the baseline liver, but all of them had normal baseline subsequently and all completed the therapy except for 1. So none of the patients had liver-induced injury according to the guidelines when they were on Esmya. That in the phase 1, phase 3 trial, and they had to check that. So let's look at this patient. The case 1, if you look at all these patients, 2 of these patients were postmenopause and they were put on UPA. The recommendation is the patient on postmenopause are not supposed to be started on UPA. And if you look at this patient, all the patients before starting UPA had some liver problem. and they had hepatitis, ongoing hepatitis, and they had one patient had already pre-existing chronic hepatitis, and one, this 45-year-old, had fulminant hepatitis before the start, and also hepatitis E. So these patients are the ones that were quoted in the literature. So when they were looking at all these patients, they couldn't rule out whether, or they couldn't confirm or rule out whether Esmya is a cause. But let's look what is DILI. DILI means drug-induced liver injury. The drug-induced liver injury are divided into two groups. One is intrinsic cause, and the other one is idiosyncratic cause. Intrinsic cause are the ones that are related mainly to medications. Now, UPA is not listed as one of the drugs causing DILI, that means drug-induced liver injury. If you look at the databases, you can just check the databases. There are more than 100 drugs which is listed as potential cause for DILI, and one of those drugs is Panadol, paracetamol. Paracetamol can cause more DILI than Esmya, because Esmya is not listed in one of it. But they had to look at it because that's one of the concerns. And if you look at DILI in the US, it's one of the main cause of hepatitis, 10%, and it's one of the main cause of liver failure, DILI itself. So after looking at all the evidence, then they made a conclusion that Esmya was not directly related to the drug-induced liver injury which was reported in this patient, so they left off the recommendation of restrictive recommendation last year and early this year. So now we're allowed to use it, but now that there's a new recommendation because of this. It's the same like WHI. WHI study, even though it's a bad study, but we still need to look at WHI in terms of postmenopausal therapy. So it's the same. So after this, so now the current recommendation is, if you want to start UPA, even though the original data from phase 1 to phase 3 trial say that it is safe and there wasn't any patient who had DILI, the current EMA recommendation is, before we start the UPA in any patient, you have to do your liver function test. So if the liver function test is normal, what you say is abnormal. If abnormal, if the ALT or AST is more than 2 times baseline, or if the bilirubin is more than 2 times baseline, that is considered abnormal, then you cannot start your UPA. But if it is normal, then you can start your UPA. So the current recommendation is, within the cycles, the first month, the first course and the second course, you're recommended to do the liver function test monthly. But after the second course, and you continue with the third course or the fourth course, then you're not recommended to do the liver function test monthly. You can just opt not to do it, or you can opt to do it just after each course, but not monthly. So currently, that's what we are doing in UMMC. So all new patients who are starting on UPA, and all the old patients who have started on UPA, we took a liver function test just as a baseline, but that is after we started it, and all the patients had normal liver function test, and in the current new patient, we take a liver function test before we start the UPA. So let me just give you some of the examples that we had in a UMMC. So we started giving our patients UPA in somewhere in 2016, and this patient, 43 years old, presented with abdominal distension, and she had heavy menses. The uterus was 18 week size, and she was not keen for any surgical procedure, even though it was planned for a surgical procedure. And the 9th of January 2017, she was planned for hysterectomy. But she decided to try the Esmya because she was not keen originally. So we started her on the Esmya in October 2016, and within 2 months of taking the Esmya, the size of the myoma reduces from, if you can see here, it was about 11 centimeters to 12 centimeters to about 6 centimeters within 2 months. And there's another patient, we also started her. This patient was still having her menses. She has not reached her menopause, and she's nulliparous, Her uterus was 16 week size, and she also presented with anemia because of heavy menstrual blood loss, and she's also planned for TAPSO, and because of the multiple myomas, and because the uterus is 16 week size, and because she presented with anemia, even though she was not keen. So she started on Esmya in October 2016, and she complained of hot flushes for about 1 month. But when we checked her estradiol level, so it was still within the lower limits of normal, but she's 50 years old. But after that 1 month, it went off, and she has no other complaints subsequently. So she completed 2 courses, and when 2 courses, the fibroid become much smaller. Initially, the uterus was much bigger on the top here. And on the top here, you can see the uterus was much bigger, and she had so many fibroids. When she's completed the 2 cycles, the uterus was much smaller, and she decided not to go ahead with the surgery. So we had another patient, 46 years old. She's also nulliparous, and she presented with this severe dysmenorrhea and heavy menses. She had tranexamic acid initially. Her hemoglobin was fine. Uterus was also enlarged. Again, she's also started on Esmya, and after 2 months, the uterus reduced significantly, and she also had her symptoms of the heavy menstrual blood loss and dysmenorrhea also became much less. And there's another patient, and she also presented the same, and she had multiple uterine myomas. And this is the first month post Esmya treatment. The uterus was just slightly, the fibroid was just slightly smaller, but after 2 months post UPA, the fibroid was much smaller, and her symptom was much less. Now I just wanted to show you this one patient. She is a 35-year-old para-1. She came to us with subfertility, and she had irregular menses, and she has no dysmenorrhea. She had been trying to get pregnant. So when we did an ultrasound, she had a very large posterior fibroid, 7 cm, and she had a few more small myomas at the back. The endometrial cavity was displaced, and she again agreed for Esmya. So we thought of putting her on 4 cycles. So we started her on the Esmya. So initially, the fibroid was larger. We couldn't see the endometrium. Later on, the fibroid was smaller after 2 courses. And by the time she had the 2 courses, and it was a time where the EMA stopped for us to prescribe the Esmya, so we didn't give her any more Esmya. We stopped in January 2017. So later on, she came back to us just as a follow-up, and the fibroid has grown bigger, and it's about 7 cm, and then there was a smaller fibroid at the back. So she decided to restart on Esmya, so we restarted her on Esmya. And oops, what happened to it? So there's 1 slide missing. So what we did was we did her liver function test, and her liver function test was normal, and we restarted her on Esmya, and so far she has completed the 3rd course, and she's going for the 4th course. So in conclusions, I think now we have more effective medical options in terms of managing uterine myomas. And we know that there are women out there who does not want to do any surgical option. I think now it's not that we put off the surgical option because there are poor responders to this, or there are myomas which large and need a surgical option. But now we have an alternative which is more effective in terms of medical option, and ulipristal acetate has been shown to be safe and effective in terms of reducing the rapid control bleeding, in terms of reducing this side effect, improving the quality of life, and do not need an AMPAC therapy. Because we know that now, we know for sure that even if you put in on the UPA for a long time, for 4 cycles, and currently in the West, they are even doing it a continuous cycle, and there was no reason to put in AMPAC therapy because the estradiol level are within the normal range. So there's potential use of long-term use of Esmya, but it does not mean that we do not offer surgical management, because there are some patients who would need a surgical management, and we would say that 20% of the patients will be non-responders, and these patients will at the end will need a surgical option. Thank you very much.